I'm Swapnil Hiremath. I'm a nephrologist from the University of Ottawa in Canada. Joining me today is my co-moderator, Dr. Rebecca Ellis.
Hello, I am a nurse scientist and associate professor at Indiana University.
And our special guest today is Dr. Niteesh Choudhry.
Thanks for having me. I am a professor of medicine at Harvard Medical School and the Harvard School of Public Health. I'm an internal medicine general internist hospitalist by clinical practice.
When we think about the definition of adherence and what it means, we need to be thinking about this concept of shared decision-making. And that is how we work with patients and have an agreed approach on how we're going to take care of them.
It is our paradigm of thinking about adherence is one now of partnership, but this all stems from the original term, which is compliance, which has a very clear connotation of rule following. I am the doctor, I prescribe, and you obey. And we have long now, thankfully, understood that that's both an outmoded and an ineffective way to build a therapeutic relationship. So I think the conventional, widely used term in practice now is non-adherence.
We know that patients, you give them a prescription, and about 5 to 10% of them will not even fill the prescription. They will walk out and they will dump the prescription. And that is for a reason, right? Sometimes we don't communicate the need to take the medications quite clearly. But even over a period of time, we find that slowly, for whatever reason, they have side effects or they don't notice any benefit, the adherence rates drop down. And there is some data to suggest that maybe at 1 year, maybe 40 to 50% of patients may not be adherent anymore to their prescription patterns. The other aspect is whether they are taking the medications on a particular day. Some people are missing their pills. The problem perhaps is even worse when it comes to resistant hypertension, where the issue of non-adherence may be higher. And whether this is because the patients who are non-adherent are likely to not have uncontrolled blood pressure, or there is something else that is going on. And the data suggests that anywhere from 30 to 40% of patients who are labeled as resistant hypertension actually may just be non-adherent.
I think of non-adherence as a common behavior and effectively a normal behavior. If half of people don't take medications as prescribed, then it can't be abnormal per se. It may be undesirable, but it is quite normal. And from that perspective, normal behavior has lots of different influences. And it is rarely about one of those, it's usually multiple. And so the way that most of us now think about non-adherence is that it's a complex interplay between patients and the healthcare system and physicians. And we all have a part to play in it. As we think about adherence as a construct, I say we put it in those terms. It's not about the patient being bad. It's about the complex interactions and the things that are necessary for adherence to happen.